In this podcast, I'm going to consider disease of the upper GI tract, so the esophagus and stomach. In the second podcast, I'm going to look at disorders of small intestine, large intestine, and appendix. And in the last podcast, I'm going to look at anal and perianal disease, disease of peritoneal cavity, and then lastly finish off by considering some functional gastrointestinal disorders. So, upper GI disease. The most important pathological processes affecting the upper GI tract are inflammation and tumours, and you can't really go far wrong by considering these processes first when you suspect a pathology in either the esophagus or the stomach. It's also important to note that infection and neoplasia in these disorders are often highly interrelated with the classical metaplasia, dysplasia, carcinoma pattern. So, firstly, diseases of the esophagus. These include gastroesophageal reflux disease or reflux esophagitis, oesophageal carcinoma, and then finally infections, achalasia, and radiation-related esophageal disease. So firstly, GORD. GORD, or gastroesophageal reflux disease, is also known as reflux esophagitis and is caused by reflux of gastric contents from the stomach into the lower esophagus. As the squamous lining of the esophagus is not designed to resist the gastric juices, it becomes inflamed, leading to esophagitis and the symptoms of GORD. Important risk factors for the development of GORD are conditions associated with increased intraabdominal pressure, such as pregnancy postural effects, as well as the presence of a sliding hiatus hernia. This occurs when the gastroesophageal junction is drawn upwards so that a pouch of proximal stomach is abnormally located in the thorax. This is a problem because the function of the gastroesophageal junction as an anti-reflux barrier is removed. The classical symptoms of GORD are retrosternal pain or heartburn. However, any kind of upper abdominal syndrome may occur. There are two important sequelae to esophagitis, and they are the peptic stricture and Barrett's esophagus. With a peptic stricture, there is a benign narrowing of the esophagus caused by scarring and deformation of the muscular wall. These are important because they can mimic the appearance and symptoms of a narrowing due to an esophageal carcinoma. Barrett's esophagus is incredibly important and is defined by columnar metaplasia of the lower esophagus. It is visible macroscopically, as normal squamous epithelium of the esophagus is white and keratinized, and Barrett's epithelium is bright red. Importantly, Barrett's esophagus is a precursor lesion of esophageal carcinoma, with a risk that is greater by about 50 times. Importantly, the development of an invasive adenocarcinoma in an area of Barrett's esophagus is preceded by a phase of dysplasia of the columnar epithelium, in which the glandular epithelial cells appear neoplastic microscopically, but invasion through the basement membrane has not yet occurred. Dysplasia can only be diagnosed microscopically, and this is another important reason for biopsying areas of Barrett's esophagus at endoscopy. All patients with Barrett's esophagus should be considered for entry into a surveillance program, perhaps with endoscopy every 2 years. However, it should be appreciated that the actual risk of death from adenocarcinoma in an individual patient with Barrett's esophagus remains very small. If, however, dysplasia is seen microscopically, it may be divided into low-grade or high-grade. Low-grade patients are followed up roughly every 6 months with rebiopsy, while high-grade patients undergo esophagectomy. So now I'm going to talk a little bit about esophageal carcinoma. So esophageal carcinomas are malignant epithelial tumours arising from the epithelial lining of the esophagus. They are divided into two types, squamous cell carcinomas and adenocarcinomas. Squamous cell carcinomas are related to heavy smoking and alcohol intake, while adenocarcinomas are related to Barrett's esophagus. As with all other squamous cell carcinomas, these are malignant epithelial neoplasms that show evidence of squamous differentiation. They may occur anywhere in the esophagus, but the middle third is the most common site. In addition to heavy smoking and alcohol, the motility disorder achalasia is also associated with an increased risk. Adenocarcinomas are neoplasms that show glandular differentiation, such as gland formation or mucin production, As they are associated with Barrett's esophagus, they usually arise in the lower esophagus. Presentation of esophageal carcinomas is usually late with rapidly progressive dysphagia for solids, as well as systemic signs such as general malaise and weight loss. Prognosis is generally poor in esophageal carcinoma, and a minority of patients with a potentially resectable tumour can be considered for esophagectomy. So lastly, in the esophageal section, I'm going to talk a little bit about achalasia. Achalasia is a motility disorder of the esophagus in which the lower esophageal sphincter fails to relax in response to swallowing, and the smooth muscle of the esophageal wall fails to propagate the peristaltic wave successfully. In addition, there is usually hypertrophy, and the esophagus becomes dilated and filled with fluid and food. The cause is thought to be immune-mediated destruction of the myenteric plexus, and presentation is with a slowly progressive dysphagia to both liquids and solids. Because this presentation is fairly similar to esophageal carcinoma, endoscopy is vital. The most serious complication of achalasia is the development of squamous cell carcinoma. So that completes really what I wanted to say about diseases of the esophagus. I'm now going to go on to talk about the stomach. Firstly, some basic ideas. The stomach can be divided into 4 compartments. The cardia, which is where the esophagus joins the body of the stomach. The fundus, so the bit of the stomach that lies above the esophageal gastric junction. The body, which incorporates most of the stomach, or corpus. And the antrum, which is the bit of the stomach next to the pylorus and entrance to the duodenum. As a major function of the stomach is chemical digestion mediated by various acids and pepsin, there is a continuous threat of autodigestion, so the stomach requires mechanisms to defend itself. Importantly, there is a surface mucus barrier, which provides the first line of defense, with an additional protective layer of bicarbonate ions secreted into this mucus by surface epithelial cells. Blood flow through the mucosa is also critical in defense by enabling disposal of hydrogen ions diffusing in from the gastric lumen. Like the esophagus, inflammation and tumours are the most important conditions of the stomach. However, the underlying etiologies in the stomach are quite different from the esophagus, and in the stomach it's always important to think of Helicobacter pylori and the use of NSAIDs. So I'm now going to go on to talk about gastritis and its many causes. I'm then going to talk a little bit about peptic ulcer disease, and then lastly I'm going to consider the various malignancies of the stomach, including carcinoma, lymphoma and stromal tumours. So gastritis, strictly speaking, means inflammation in the stomach, characterised endoscopically by redness of the gastric mucosa. The most common cause of gastritis is Helicobacter pylori infection. Helicobacter pylori is a gram-negative bacterium that survives in the hostile environment of the stomach by using its flagella to move to the antrum, which is the least acidic area. The bacteria also take advantage of the thick mucus layer of the stomach and neutralize any gastric acid they come into contact with by ammonia that's generated from urea by the urease enzyme found in the bacteria. H. pylori therefore sets up an antral-predominated gastritis. However, from here, there are a variety of outcomes involving interaction of a number of factors relating to both the virulence of the particular strain of Helicobacter and the individual's own defences. The most important factor seems to be the level of acid secretion in the stomach. So in 80% of patients, Helicobacter pylori infection results in an asymptomatic pangastritis, as because their acid levels are slightly reduced, bacteria can spread proximally into the stomach and set up this mild inflammation. As we've said, these patients are usually asymptomatic and there appears to be no significant sequelae to this. However, in another group of patients, known as acid hypersecretors, Helicobacter infection causes a large increase in acid secretion, possibly due to a negative effect on the somatostatin secreting cells located in the antrum. Excess acid passes into the duodenum and causes inflammation of the first part of this structure. In response to this, the duodenal epithelium undergoes gastric metaplasia, presumably in an attempt to protect itself. However, this is a deleterious response because it allows the first part of the duodenum to be colonized by Helicobacter and leads to more inflammation, eventually leading to peptic ulceration. In the remainder of patients, there is a marked decrease in acid production. The low acidity allows bacteria to heavily colonize the body of the stomach, causing corpus-predominated gastritis. A cycle is then set up as the gastritis further depresses acid secretion with further colonization and further inflammation, etc., etc. Over time, there is destruction of acid-secreting glands, leading to chronic atrophic gastritis and gastric epithelium metaplasia into intestinal type. The presence of intestinal metaplasia is important as a marker for the risk of the development of gastric carcinoma. Autoimmune gastritis is an organ-specific autoimmune disease that's associated with destruction of gastric parietal cells. These parietal cells are important in generating acid and are found predominantly in the gastric glands located in the body and fundus of the stomach. Inflammation is therefore concentrated in the body and fundus, and this distinguishes it from the pattern seen in Helicobacter gastritis, where inflammation in the antrum is dominant. Over time, autoimmune gastritis leads to extensive destruction and atrophy of the acid-secreting glands, accompanied by intestinal metaplasia. There is therefore a risk for the development of gastric carcinoma. Some patients also develop pernicious anemia. Reactive gastritis or chemical gastritis is another very common cause and is usually due to the ingestion of gastric irritants such as NSAIDs and alcohol. Lastly, erosive or hemorrhagic gastritis refers to a pattern where a large number of defects in the gastric mucosa occur. There are two major settings in which this happens. Firstly, following ingestion of large amounts of NSAIDs, aspirin, or alcohol. The second situation is in the acutely unwell patient, where, often due to a reduction in blood flow to the stomach, there is not as much removal of hydrogen ions. For this reason, prophylactically these patients are usually given a proton pump inhibitor. Importantly, erosive or hemorrhagic gastritis usually heals rapidly and seldom recurs as long as the cause is treated. So I'm going to do a little summary now about gastritis because I think it's quite a complicated topic. So gastritis refers to inflammation in the stomach. Infection with Helicobacter pylori is the most common cause of this. While most patients remain asymptomatic, some may develop complications including peptic ulceration, gastric carcinoma, and gastric lymphoma. Autoimmune gastritis is due to immune attack on gastric parietal cells in the body of the stomach. These patients often present with a megaloblastic anemia due to lack of intrinsic factor secretion. Autoimmune gastritis is a risk factor for the development of gastric carcinoma. Reactive gastritis is a common cause of erythema of the gastric mucosa that is seen at endoscopy as a result of mild damage caused by irritants such as NSAIDs, aspirin, and reflux from the duodenum. Erosive or hemorrhagic gastritis describes a situation in which multiple defects form in the gastric mucosa from which bleeding occurs. This may occur following ingestion of large quantities of irritants or in severely ill patients. So now I'm going to talk a little bit about peptic ulcer disease. Peptic ulcer disease differs from gastritis as there is a full thickness breach in the mucosa of the lower esophagus, stomach, or duodenum. Peptic ulcers are usually solitary and located in the antrum of the stomach or the first part of the duodenum. The vast majority are seen in patients with an antral predominant gastritis plus acid hypersecretion, while the remainder are most probably due to NSAIDs. Endoscopically, they have a punched-out appearance with clean edges. Important sequelae of peptic ulcers are hemorrhage, perforation, and fibrous stricture. In hemorrhage, often seen secondary to erosion of these ulcers on the posterior wall of the duodenum into the gastroduodenal artery, there is massive hematemesis. With perforation, there is acute abdominal pain and the rapid development of peritonitis. And in fibrous stricture, there may be gastric outflow obstruction with persistent vomiting and abdominal distension. So lastly, I'm going to talk about some of the gastric malignancies. So these are carcinomas, lymphomas, and stromal tumours. First thing to say about gastric carcinomas is that most of them develop on the background of chronic atrophic gastritis and intestinal metaplasia due to either Helicobacter pylori infection or autoimmune gastritis. Virtually all of these carcinomas are adenocarcinomas, therefore showing evidence of gland formation or mucin production. There are two types recognized: intestinal type and diffuse type. The intestinal type arises from the sequence of atrophic gastritis, intestinal metaplasia, and dysplasia. The falling incidence of these cancers is largely due to decreasing rates of this infection. Diffuse type arises from normal gastric mucosa and has characteristic signet ring cells caused by large amounts of intracytoplasmic mucin pushing the nucleus to one side. It is usually a highly infiltrative cancer encasing the entire stomach wall with tumour, producing the so-called leather bottle stomach, or lanitis plastica. Now I'm going to talk a little bit about lymphomas. So lymphoma is a neoplasm derived from mature B lymphocytes that left the bone marrow and taken up residence in other organs. The stomach, however, normally has no lymphoid tissue within its walls, and immune surveillance really is due to an acidic environment. However, inflammation with Helicobacter induces inflammation and lymphocytes are recruited into the stomach wall. In a small minority of these patients, continued stimulation of B lymphocytes can lead to emergence of a neoplastic clone. This is typically a low-grade type of B-cell lymphoma known as marginal zone lymphoma. Distant spread is unusual, and often these lymphomas will progress in response to antibiotic therapy for Helicobacter pylori. Lastly, I'm going to talk about the gastrointestinal stromal tumour, which is an uncommon neoplasm most often found in the stomach. It's a neoplasm of connective tissue origin, thought to be derived from pacemaker cells of the bowel, i.e. those cells that are responsible for controlling the peristaltic wave. One of the features of these tumours are overexpression of a mutated form of tyrosine kinase KIT. They are usually exophytic tumours which have central deep ulceration and therefore often present with abdominal pain or hematemesis. Most of them are treated with surgical resection. However, in unresectable or metastatic cases, imatinib, that's often used in CML for uncontrolled tyrosine kinase activity, is highly effective.